Hello. In this section we'll consider how to actually fit a gas panel contact lens. What's the process, what's involved, and what do we as practitioners need to do? How to fit an RGP? We mainly fit them empirically now. So all modern gas panel lenses that we fit in high street practices generally are fitted empirically from a set of measurements. Now this is because of the variant CJG disease which came about a few years ago. Now this is a fatal, however very rare, but still fatal prion disease. So no fitting sets have been used since that time. There is an exception in some hospital practices where fitting set lenses are necessary because of the complex nature of the patients that we are seeing. However, there is a very strict and rigid decontamination process which must be used with all reused fitting set lenses. But as we say, for most patients that we're going to see in high street practice, empirically is the way forward. Now, we need a set of measurements from you, the practitioner, to us as manufacturers. Obviously, we need an up-to-date spectacle prescription, a vertex distance if this is over ±4, some good keratometry readings, a horizontal visible iris diameter, and in some instances, particularly if we have very narrow eyes, a palpebral aperture. So we calculate the power of the lens from the spectacle prescription. If the lens is going to correct the corneal astigmatism, then we only need the spherical part of the prescription. So if the cil power and the keratometric astigmatism match, we just purely use the spherical power of the prescription. We need really good, accurate keratometry readings. As you will know, flattest K is used for a spherical lens fitting. However, a lot of patients have some degree of corneal astigmatism. So if we go over about a diopter and a half, or a 0.3 difference between flat and steep, then we need to know those measurements, both of them. If the corneal astigmatism is over 2.5 diopters, or there's a 0.5mm separation in keratometry readings, then we need to consider a back surface toric. The thing to watch out for is that the corneal cil and the spectacle cil don't match up. This can often indicate some residual cil, and what we would potentially need to do then is create a bitoric lens with a toric back surface to correct the corneal astigmatism and a front toric to correct any residual astigmatism. In terms of measurement, there's several different instruments that we use. Traditionally, we've had either a 1 or 2 position keratometer, and most practices should have one of these instruments. Now, traditional keratometry only gives us information about the central 3mm. It doesn't tell us anything about the peripheral cornea whatsoever. So corneal topography has become much more popular over the last few years, and a lot of practices will have a topographer within their consulting rooms. This gives us a lot more information about the patient's cornea and will extend out limbus to limbus. Because of this extra information, it enables us to fit lenses more accurately and faster with fewer visits. The one position keratometer, which has variable doubling and fixed mires, is a very quick and easy instrument to use. However, if your patient has a slightly irregular cornea, then the 2 position, which has the fixed doubling and variable mires, which can be adjusted in either meridian, will be more accurate. When we're asking practitioners for a set of measurements, we'll always ask for a visible iris diameter. The horizontal visible iris diameter is what we use to determine the total diameter of the lens. Now, it can be measured with a ruler. We would like you to check it for every patient that you fit with gas panel lenses, and it's particularly important if the patient has an especially large cornea or small cornea. The average HVID is around about 11.5mm. Often it's not 12mm, which is a measurement that's quoted. If we take the HVID and subtract 1 to 1.5mm, that's going to give us the total diameter of the lens. Now, over the years since we've been fitting gas panel lenses, the average size of the lens has increased. So in the 60s, 70s, diameters of 8.5 to 9mm were fairly common. Even up to about 25 years ago, 9mm lenses were still fitted fairly regularly. However, lens diameters have increased generally, and this is for several reasons. One is that we have better performance in terms of permeability to oxygen with lens materials. This allows us to cover a larger part of the cornea without causing any hypoxia. Larger lenses generally are more stable, they center better, which is particularly important for multifocals, and they're more comfortable, they create less lid awareness for the patient. So often we're looking at diameters of 9.8, even 10 or 10.2 if the patient has a large HVID. So to summarise, accuracy of the measurements is key to success. The more measurements you give us, the better the result and the greater the success rate. For pretty much all patients now, choose a good, high quality, high decay material and make the diameter of the lens as large as possible. Please do have a look at the fitting guide for each lens. It may be slightly different. Some lenses are fitted on flattest K, some are fitted 0.5 or 0.05 steeper than flattest K. And manufacturers are here to help you with any queries that you might have.